Hi, good evening, everyone. I'm very happy to be here with Dr. Teller to talk to you about public health for Module 7. Our learning objectives are to understand the maternal child health leadership competencies, to understand the public health competencies and how they align with maternal child health priorities, to recognize the importance of data and using the public health approach to informing public policy, hence the exercise you'll be doing later today, and to describe the Flint water crisis as a public health problem. So we were hoping in our second half of our session today to have Dr. Lauren O'Connell, a pediatrician from Hurley Children's Center, speak to us on the Flint water crisis. Unfortunately, she had some pretty significant computer problems, so she is not able to present today. So what we're going to do is that we will have, we are working on finding another time for Dr. O'Connell to give her presentation. It will be a webinar, and we'll let you know as soon as we have that time. We hope all of you will be able to join, but given that it's sort of an impromptu kind of thing, we understand if you can't, and we'll also have that recorded. So for today, we expect that we hope to finish up no later than 6 o'clock. Let's begin with what is a maternal child health leader. A maternal child health leader inspires and brings people together to achieve sustainable results to improve the lives of the MCH population, that is, women, children, and families. And this definition comes from the MCH Leadership Competencies Work Group. And trainees, we've told you several times, and I'll say it again, that you were selected because you exhibit leadership qualities. And we know that leadership development is a progression, and leadership ability grows as one deepens their knowledge, skills, and experiences. So hopefully this looks familiar to you. This is something that we shared on our first day together at our first face-to-face session, and this is the MCH Leadership Conceptual Framework. And this schematic demonstrates the growing influence that a maternal child health leader can experience over a professional lifetime. And the MCH leadership competencies are presented as a progression from self, so that inner circle, then to others, the blue circle, and then finally to the wider community. The leadership process begins with a focus on self, where leadership is directed at one's own learning through readings, instruction, reflection, and experiences. So in this domain of self-leadership, there are 4 competencies. These include maternal child health knowledge base and context, and this includes the history and current structure of maternal child health programs serving women, children, and families, as well as services available through major MCH programs. So there is, and I hope you've seen this from your readings, or you will see this from your readings for this week, that there is a strong connection between public health and maternal child health. And in your readings, there was an article on MCH Public Health 101 where you'll see that strong overlap. And there was also included a video introduction to public health that was made from the CDC. So we're hoping that a lot of that content, you'll get it from there, because the didactic pieces around public health you can get from that video. Also included in self-leadership are self-reflection, ethical behavior and professionalism, and critical thinking. So I just wanted to pause for a moment here to hear from the trainees. What things have you done through the LEN, formally through the LEN program, or just on your own, to develop your self-leadership skills? So feel free to unmute yourself, and just, I have a few thoughts of things I hope you'll answer, but wanted to hear from you.
Well, I've been seeking feedback just on my own experiences with supervision, and just seeking what other models of supervision look like just to improve my own practice.
Great. And Ramsey, have you been doing that with your mentor, or are you doing it in your clinical practice, or both?
It actually happens across different contexts of interactions. I have different supervisors that are for different settings, but I try to seek the same from most of my supervisors.
Wonderful. Thank you.
Yeah.
Anyone else?
And this is Erica. I guess what I would say is that I've been obviously gaining a lot of knowledge. One of those in particular, kind of just like what we did the last face-to-face, is especially with a lot of the resources, and I feel like I've been able to share a lot of those in the department, and now have a lot of people coming to me in that role and asking me where to send people.
Great. Thank you. Anyone else?
This is Michael. Looking at the self-reflection stuff, there were some assignments that we had to do where we had to take some cultural competency questionnaires and see how we scored on that, and that really helped me reflect on what kinds of things that I need to work on as far as the cultural competency goes, because I think partly because I'm in rural Michigan, but it's definitely something that's opened my eyes on some of that stuff.
Great. Thank you for sharing that. Others? Anyone? Any other? I feel like we had quite a few self-assessments, certainly at the beginning. Other self-assessments, other people, with whether it's the culture related to cultural competence or other self-assessments, did others find that useful?
This is Molly. I thought that the Finding Our Strengths, that assessment was very useful. I think it opened a lot of our eyes with how truthful a lot of them were. And I just remember when we shared our top strength and reflected on that, I think everyone was sort of surprised, but also agreed with their top strength. And so I think that's something that at least I personally had not explored before. So I think understanding our strengths will really help with developing our leadership.
Thank you.
And this is Maddie. Something that I've found that's been really helpful in terms of sort of self-reflection, but also learning about others' perspectives. Every time we have one of those face-to-face meetings, I always find that the most profound moments are hearing from some of the parents. Working in audiology, we do have a lot of children who have comorbidities. And so it's not necessarily a direct, I'm not working exclusively in that field. However, I just felt that every time we meet, I leave really thinking about how I interact with families and how I can better, focus on their needs and their wants and take into consideration the other things that
Thank you. And, I appreciate you saying that, and I don't know how others, one of the things that we hope that you're doing is definitely leaving these sessions and having these interactions and reflecting on the experience, but also through journaling and looking at those life perspectives, but journaling. I'm curious if others are doing any kind of reflections through journals or some of the assignments.
Shanae, you're now unmuted. You can go ahead if you have a comment.
Yeah, so not quite along that line, but one of the things I was thinking was now, when I see a patient that's coming in and I know they have a neurodevelopmental disability, I've been able to look at some of the things we've talked about and presented about just to make sure that I'm thinking about all of the parts and pieces. So making sure that I'm referring to the appropriate people by looking back to review, kind of all of the things we've talked about.
Oh, great. Thank you for sharing. So the next sphere is labeled others, and this is where leadership extends to others that you work with, such as your coworkers, your colleagues, the families you work with, fellow students, and there are several competencies that are listed here, and those include communication, negotiation and conflict resolution, cultural competency, family-centered care, developing others through teaching and mentoring, and interdisciplinary team building. And one of the things that struck me when I was looking at this again was that we had looked at this when we were writing and preparing for our LEND application, was that we came up with the life perspective. So I think for me, the life perspectives kind of leaped off the page, although there's more than the life perspectives here. So that's one thing I do want to hear from you, how you're finding if the life perspectives are a helpful way to think about these leadership competencies. Another thought I just wanted to point out around communication, the communication includes verbal, nonverbal, and written sharing of information, and involves both the message, that is what's being said, as well as the delivery method, how the message is presented. So I just wanted to open up here for any discussion on things that you're doing through the program, or sort of formally through the program or outside of the program, to help with these leadership competencies. So I'll open it up.
This is Molly again.
Go ahead, Molly.
One thing that jumped out for me on this page is developing others through teaching and mentoring. Right now, we're in the process of transitioning leadership for various organizations at school. So we've been having transition meetings and helping the first-year medical students with all the questions they have about how they can successfully lead various organizations. So that's one thing that jumped out at me that I've been doing a lot of lately.
Great. Others with either that competency or any of the others listed here?
So this is Shanae. One of the things that jumps out at me is the communication. So when I am writing reports or letters at work, one of the things I've been really trying to be cognizant of is the audience that I'm writing it for. So I think, throughout this we've talked about appropriate language and just making sure that, we're not presenting things in too medical terms. We're presenting things on the level of the intended audience.
Great. And included in this, feel free if you feel like there's certain things. I would welcome the feedback if you feel like, oh, I wish we had more of any one of these.
So I was just going to bring up one of the things we kind of talk about as a group among the trainees is we're hoping for a little bit more of the interdisciplinary care among each other. So I know, like, for example, Ramsey has a lot of clinical experience with children with autism. And I think a lot of, just among the trainees, a lot of us have good experiences to bring to the table that we could use to teach each other. So maybe more time to do interdisciplinary work among ourselves.
Yeah, and thank you for saying that. And we have been hearing that in the feedback and from you, which is so helpful, not just you, Shanae, but from all of you, which is so helpful. And one of the things that we're working on is to allow for more time to apply, have settings where you can come together and work together as an interdisciplinary team. So thank you for that. That's something that we will definitely be working on. And Maddie, was it you that that had chimed in?
Yeah, it was, again, just along those same lines, just because it's something that came up a lot at the last meeting. I do think that, again, there is a lot to be learned from each other, and, I kind of pinpoint in my head one specific activity that I thought was useful, but where we were sort of assigned a role and asked to look at a case study from another perspective. And while that's a useful exercise in some capacity, I felt like, again, we do all have such a great knowledge base in our own area. I feel like I can talk about audiology, but not very much, only very basic knowledge of ABA or psychiatry. So I don't know. It felt, again, I think it just goes back to really working and learning from each other, because from the conversations I had with my peers and the other members of the cohort, I know that there's a ton that they could teach me.
And I couldn't agree more, and I really appreciate that feedback, and we'll definitely work on that. Thank you. Any other comments before we go on to the next part of the schematic here? Well, thank you again for that feedback. So the next slide looks at the wider community, and we know that leadership can extend to a broader impact on entire organizations, systems, or general modes of practice. And these wider areas of impact and influence require additional skills and a broader-based understanding of the change process and the factors that influence change over time. And improving the health status of maternal child health population groups is very complex because there's so many factors that influence the health of children, adolescents, and families. And reaching a goal of promoting health and preventing problems requires a broad-based systems approach to the issues. And systems thinking is the ability to appreciate the complexity. And this includes the ability to see the whole and the parts and to understand the ways in which the parts interact and influence outcomes. So this is really, as we said, this is a progression. So this is where we are today, and this is where we intend to focus our program for the remainder of the program. So one of the things that we'll be doing for the next 2 webinars is bringing it to this wider community level, more systems of care. We, and we'll have Dr. O'Connell, of course, give her talk on the Flint water crisis. And then at our last face-to-face session on May 19th, we'll have an overview of national policy as well as state policy perspectives. And one of the things that struck me the other day at our face-to-face session was that we started getting into a conversation around policy. And as I mentioned at that time, we really could have a whole program on policy or these wider community issues. So we know we won't have time to cover that, but one of the things that we do plan on doing is Angela Martin from my team is an expert in policy, and she's going to create a webinar. I don't know if it'll just be offered, it'll be taped and offered, or we'll offer it live, but she'll give a primer on policy so that to help give some more information to tee things up for when we talk about policy at our last face-to-face session. And we're hoping that the exercise that you did for today will get you, again, it's more a thought exercise to get at that big picture thinking. So I didn't know if there were any comments or thoughts. I know we'll be doing the presentations a little later, but I'll open it up for a moment now if anyone has anything they want to add or say about that. So listed here, this refers to public health competencies. And what I have listed here aren't public health competencies, but they are domains in which public health competencies fall. So under each of these domains, there could be 7 to 10 competencies. So rather than going through them all today, we just don't have that time. And I think your reading materials, as well as that public health video from the CDC, along with the maternal child health, has a whole public health navigator. You can dig deep on all of these. But I wanted to look at that overall big picture view of these competencies. And as I mentioned before, public health and maternal child health, there's a lot of overlap. And when I looked at these competencies such as analytical assessment skills, policy developmental program planning skills, communication skills, cultural competency, community dimensions of practice skills, public health sciences skill, financial planning and management skills, leadership and systems thinking skills, to me, seem to align quite closely with those maternal child health leadership skills. So I just wanted to open it up for a minute here to see if anyone has any reactions to these, any that seem different, or does it seem like a complete overlap? Do they seem quite similar to you? I'll take that as a yes, unless anyone wants to say otherwise. I think that, again, there's just a lot of overlap there, and this is why these competencies, the maternal child health competencies, are included in this module. I'm going to talk a little bit just about public health and compare it to healthcare or clinical care. And there are a couple points I want to make on this slide, just a couple key differences. And that is the focus. So public health focuses in on populations or groups of people, and clinical care typically focuses in on the individual patient. And then another key difference is the emphasis. So in public health, there is an emphasis on prevention, health promotion, wellness, where in clinical care, it's typically around diagnosis and treatment. And both are extremely important, and they're complementary to each other. So when they work collaboratively, all people benefit. And I wanted to take a moment here to talk a little bit about population health. And this is a little bit nuanced. And when I was in graduate school in public health, I'm an epidemiologist. 20 plus years ago, I had never heard of population health. And I'd say probably in the last 10 years, people have been talking about it more. And sometimes the definition of public health and population health are used interchangeably. But for myself, the way I view it and the way I distinguish it is that population health is not just the overall health of a population or a group, but also includes the distribution of health. So the overall health of a population could be quite high if the majority of people are relatively healthy, even though a subgroup of the population could be much less healthy, and that's what we call a disparity. And ideally, such differences or disparities would be eliminated or at least substantially reduced. So this concern with disparities is a significant feature of population health. And the other piece, which is the right side of this figure, has to do that population health addresses the determinants of health, including those social determinants of health. So that population health is also concerned with health outcomes, but also disparities in social determinants of health. So a way to illustrate this, I'm going to give you a pop quiz here, and I have a feeling you're going to do quite well on it. So Mike, I'm going to go to the question, and then I believe that everyone can answer to vote on this. Is this okay? So the question is, on average, which of the following conditions is the strongest predictor of your health? A, whether or not you smoke. B, what you eat. C, whether or not you are wealthy. D, whether or not you have health insurance. Or E, how often you exercise.
64% of how many folks, Mike?
Yes.
How many folks answered the question?
We have 14 on, in addition to us.
Okay. All right. So 64% answered correctly,
Okay.
whether or not you are wealthy.
Okay.
27% answered whether or not you have health insurance, which has a correlation with wealth.
That is true.
And then 9% answered whether or not you smoke.
Yeah, and this is interesting. So and there may be some people that are on the call that weren't before, but this is the exact question that Dr. White-Perkins shared when she gave her her session on equity. And the reason I put this back up again is that, again, this I think gets at those social determinants of health. So the answer was C, whether or not you are wealthy. And the wealthier you are on average, the better your health. From the bottom all the way to the top, genes, diet, exercise, and other behaviors, other determinants of health are important. But for example, if you have a poor smoker, they will still have a greater chance of getting sick than a rich smoker. So this is getting at that, at issues of disparities and social determinants of health. So there's one more question, and this one is the most important factor behind the 30-year increase in U.S. life expectancy during the 20th century was A, new drugs like penicillin, B, social reforms like wage and labor laws, housing codes, etc., C, the development of the modern hospital system, D, migration from the countryside to cities, or E, more exercise and less smoking.
73% answered social reforms, such as wage, labor laws, housing codes, etc. 18% talked about new drugs, or thought new drugs was the answer, and 9% the development of the modern hospital system.
Okay,
so 73%
great.
answered correctly.
Okay, and so here, again, this is the exact question that was asked in that other session, and the answer was social reforms. Researchers attribute much of our increase in life expectancy to social changes, better wages, housing, job security, and working conditions, civil rights laws, sanitation, and other protections that improved our health by improving our lives. And so part of what we're hoping in the exercise you'll be presenting today is to get at some of these, that wider community and the sort of systemic change. And I'm going to open it up just for a moment because I know that Dr. Teller has a few slides that she'd like to share before we do your presentations, but wanted to get just some thinking for those that maybe answered some of the other choices. And do you remember this question? Was this one that, because for me, it stuck with me because I remember there was quite a bit of variability in the responses last time.
Hi, this is Shanae. So I remembered this question. It stuck with me because I answered incorrectly the first time, and I thought it was funny that when you displayed it just now, my first reaction was the incorrect response, and then I stopped to think about it and realized that I knew the answer, and it was social reforms.
Great, thank you. Okay, well, I'm going to pass it over now to Dr. Teller. And Dr. Teller, just let me know when you'd like me to advance your slides.
I certainly will. Thank you, Sharon. Dr. Thomas Frieden, who was the director of the U.S. Centers for Disease Control and Prevention, developed an inclusive conceptual framework to describe the differential impact levels of health-oriented interventions. So he took an expansive view of population health determinants and divides the health impact pyramid, which accommodates both the biomedical and social determinants of health. It's depicted, as you can see in the slide, as a 5-tier pyramid, and it symbolizes how interventions have the potential for varying degrees of population impact. At the bottom of the pyramid are socioeconomic factors, which includes contextual and environmental factors and has the greatest potential for impact. Interventions at this level require at least individual effort and affect the greatest change in population health. So examples of interventions at the socioeconomic level include improving education, reducing poverty. Does that make sense to you all? I hope you're nodding your heads. Okay. At the level of changing the context, interventions are aimed at altering the environment so that individuals' default decisions become healthier. Such interventions may include adding fluoride to water or improving the air quality. Because changes at this level do not require individual level behavior change, they can be effective in impacting a large number of people. In the middle level of the health impact pyramid are one-time protective interventions, such as immunizations and cancer screenings. These occur at a limited point in time, but have the potential to impact health long-term. The top 2 tiers of the pyramid are counseling and education and clinical care interventions that require the most individual effort and affect the least change in population health. However, when applied consistently and repeatedly, these interventions can have large impacts. While interventions at these levels are intended to change behavior and improve health, they are limited by lack of access, erratic and unpredictable adherence, and imperfect effectiveness. In order to have the maximal impact on population health, communities need coordinated interventions at each level of the health impact pyramid. Each community has a unique set of barriers and assets that impact health issues and mediate the effectiveness of interventions in particular ways. So taking a context-specific approach to understanding the issues, the assets, and the barriers should improve awareness and communication and improve health outcomes. I think the biggest takeaway point from the health impact pyramid is that as you go up, you have increasing individual effort to do it. So that's when people stop smoking, things like that. While as you're going down, it has increasing public health effect. So are there any questions about the health impact pyramid? Okay, no questions? Then I'm going to move on. Next slide, please. Okay, this is Healthy People 2020. The ultimate goal is to provide evidence-based national health improvement goals for the current decade. Over the last 3 decades, the program has encouraged cross-community collaboration, including facilitating communication of the latest medical knowledge, and has attempted to measure the impact of preventive health strategies. There are 4 overarching goals of the program. The first one is to attain high quality, longer life, free of preventable disease, disability, injury, and premature death. The second is to achieve health equity, eliminate disparities, and improve the health of all groups. Third is create social and physical environments that promote good health for all and promote quality of life, healthy development, and healthy behaviors across all life stages. Currently, Healthy People 2020 tracks about 1,200 objectives from 42 topic areas. Slightly more than 900 of these objectives are accompanied by baseline data that allows for the establishment of target figures. Most of these data are available to the public through the Health Indicators Warehouse. Collaboration through data sharing is one of the primary ways that Healthy People 2020 is encouraging partnerships across all levels of government and all sizes of communities. I wanted to bring this resource to your attention. So, if you're ever interested in any of these indicators, the Health Indicators Warehouse is an excellent resource. Okay, as Dr. Milberger mentioned, there are factors affecting health. This particular model is from County Health Rankings and Roadmaps, which just released their county-level ranking. So, for example, Wayne County is 83 out of 83 in the state of Michigan. So it's the worst county in the state for health behaviors, clinical care, social and economic conditions, and physical environment. And as I stated at our last face-to-face, health is impacted by the policies, systems, and environments in which people live and function day to day. So population health is differentially impacted by health behaviors, clinical care, social and economic conditions, and physical environment. Although this model does not include genetic and biological factors, it estimates that 40% of health is affected by social and economic conditions, followed by 30% for health behaviors, 20% by clinical care, and 10% by the physical environment. Thus, schools and communities, as well as work sites, impact access to a healthy lifestyle. And one of the taglines in this and other Robert Wood Johnson Foundation initiatives, all the places that people live, work, play, and pray affect their health. So the socioeconomic, for example, income, education, risk factors that most greatly impact a community and an individual's health can be lessened through policy, systems, and environmental interventions. All of those are at the bottom of the health impact pyramid. And so that's how you can demonstrate the effectiveness of these intervention strategies. So the next slide, please. So this is a map, as you can see, and it is Wayne County, or Detroit, Michigan. And you can see as you go from one community to another how life expectancies vary. So these are life expectancies at base. And I would like you to think about it and share, why are some neighborhoods so much healthier than others? And this ties together a lot of our discussion today. So I'd be real interested to hear what you have to say.
When you look at the numbers and why, those are just indicators of a dynamic interplay of different processes that are occurring at multiple levels. So, like with the broad frameworks you have covered, are related to kind of this bioecological social dynamic system way of seeing factors at individual levels, at environmental, social, policy levels interacting that shape some of those indicators. And life expectancy as a gross outcome of these different processes is kind of what's happening. So that's how I would look at it.
Okay, so can you think of some specific examples of what some of those processes might be?
Sure. So if we look at individual level factors, you look at possible SES-related factors, household constituents, income, education level, whether you're a single parent or not, or you have multiple children that are older, younger, or who have disability. Depends on your kind of social immediate context. So there are a lot of variables there at work. And then when you look at more system level variables like the quality of safety and schools in the neighborhood and higher other social resources that are available for some but not others, and given those micro variables, and then you look at how policies at the political, business, so on, shape some of the environmental factors, which in turn affect with health and these important variables that we're looking at. So those are kind of certain examples of different variables at different levels and how they could interact.
Great answer. Does anyone else have anything to add? Ramsey mentioned education and income. Okay, communities with weak tax bases cannot support high-quality schools, and jobs are often scarce in neighborhoods with struggling economies. There's also unsafe or unhealthy housing, which can expose residents to allergens and other hazards like overcrowding or bad water. The opportunities for residents to exercise, walk, or cycle may be limited. Some neighborhoods are unsafe for children to play outside. The proximity to highways, factories, or other sources of toxic agents may expose residents to pollutants. In certain areas, access to primary care doctors and good hospitals may be limited. And we see that a lot when we contrast urban and rural, but also within urban areas. Unreliable or expensive public transport or transit can isolate residents from good jobs, health and child care, and social services, and then residential segregation that isolates communities, like highways.
Dr. Turner had a comment and question. Go ahead, Dr. Turner.
Yeah, I looked at this. I heard Tom Nahishi-Coates speak last night. He wrote the Between the World and Me, and he wrote the Case for Reparations that was published in the Atlantic Monthly. And I think if he were to look at this map, he would look in where it says 69 years, that zip code 48201. This is probably, put it in an historical context. The neighborhoods with the lower life expectancy are probably neighborhoods that were redlined for housing. The legacy of racism in our housing policies, in our housing industry, in our banking industry. And I think all that we were describing there with the lesser resources, I think there's a strong, I bet we could find a direct historical explanation of why they are as they are now, and that ties to the life expectancy.
Excellent point, Dr. Turner. Okay, I'm going to turn it back over to Sharon to do the next slide.
I am going to, for this next slide, I'm going to not go over it. This is basically was the framework for the assignment you have, because I want to make sure we have time to have you share your presentations. But this was just the key things here to note are that public health problems are diverse and can include a wide range of conditions, chronic diseases, infectious diseases, emergencies, injuries, environmental health problems, and others. And regardless of what the topic is, that in public health we take the same approach. We take these 4 steps. We have these 4 questions, and we have these 4 steps that take us from identifying a problem, so what is the problem, surveillance, to identifying risk factors, what is the cause, to determining what works, to how do you do it, to the implementation. So taking us from problem to response. So I think this was included in your assignment instructions for this week. So rather than go belaboring it, I'm going to just take us to our, allow you to do your presentations.